So Dave Boyer,
Yeah.
the other sort of comparison study, which really wasn't a comparison that came out recently, was a Harbor study. And that study looked at a 0.5 milligram Lucentis versus a 2 milligram Lucentis. Why don't you walk us through the results of the Harbor study?
Well, the Harbor study compared, as you said, the 0.5 milligrams to a 2 milligram dose with the hope that they would get better drying and better vision and perhaps longer lasting effects. So they had a monthly and they had a PRN group, but the PRN group was after 3 injections. And when the results came out after a year, there was no increased incidence of systemic adverse events. However, the visions were approximately the same between the 0.5 and the 2 milligram dose. There was no significant difference between those two doses. So whether the additional increase in the medication didn't seem to make any difference on the visual acuity or on the SAEs.
And I think that's an interesting point, because that was one of the things that we were concerned about, is that by increasing the dosage, that this would lead to additional SAEs, and in particular systemic SAEs, and that didn't appear to be the case. Was there any difference between the monthly and PRN arms?
Well, the monthly, again, did better than the PRN arm, but I don't remember the difference.
Yeah, so the monthly, the PRN was not shown to be non-inferior. So based on that, it shows you that PRN hurts you even with the higher doses and a 3-month load. And that's only at 1 year. The 2-year data will be very interesting, and I think Genentech just got that data, so it should be out in the next several months, I would think. What I was disappointed in, we showed in the SAVE study, which is coming out in this month's Ophthalmology, that in recalcitrant patients, the higher dose did dry out more patients and got a statistically significant improvement in visual acuity. Harbor, though, shows that in treatment naive, it doesn't make a difference. And so maybe it's such a small percentage of patients that need the higher dose that didn't move the needle. It also may be that with monthly therapies for continuous periods of time, you develop either resistance or tachyphylaxis or some other mechanism whereby you need a higher dose to be effective. And tachyphylaxis, in my mind, has never really been demonstrated in anti-VEGF, but it would be one explanation of why these patients might need more drug, those recalcitrant, hard-to-treat patients.
And when we looked at, for example, we dissected all of the CNV changes with 2 milligrams versus 0.5 milligrams, and we didn't really see a lot of differences when you look at cornea vascularization response. So it really does suggest that we are at the top end of the curve in naive patients in terms of the amount of anti-VEGF that we need. And so other issues then come into play down the road. But I think in terms of the amount of VEGF that's there that we need to remove versus the amount of anti-VEGF that we need to add, I think with even 0.5 milligrams of Lucentis, we're starting already at the top dose. I don't think we gain any more at these naive patients with 2 milligrams.
I think it really highlights how for the large majority of patients, I think exactly as you're saying is the case. But similar to Dave, we had a series of patients that we presented. One of my partners, Chirag Shah, presented at ASRS 2 years ago, patients who are what we would consider suboptimal responders, and we would double the dose. This is just 1 milligram. And a significant number of them had an anatomic response. There was a minimal visual response, but these were also chronic patients. I think that there are clearly patients who will benefit from higher doses, but that number is relatively small when you look at clinical trials, but it's relatively high when you look at patients that occupy our exam rooms.
And I think it gets back to this point of each patient is so individualized that you really can't make a generalized statement about 2 milligrams not working or 0.5 milligrams being the best, because yes, in the majority of patients that's true, but as you point out, Jeff, I think each individual patient has such a variety of presentations, issues, biologies that are going on that you can't really ignore all of these issues for each individual patient.